Hello, everybody. Welcome to my presentation, New Guidelines for Cervical Cancer Screening in Germany. What are the reasons for implementation of co-testing? My name is Tomas Iftner. I'm director of the Institute of Medical Virology at the University Hospital in Tübingen. Now, Germany started before the introduction of cervical cancer screening with a very high incidence rate like Denmark in comparison to other countries like, for example, the UK or Finland or Sweden and Norway. So we had almost a twice as high incidence rate as the others. So when 1971, cervical screening started by using annual cytology, starting at the age of 20 with no upper age limit, there was an immediate effect on the incidence rate of cervical cancer noticeable. However, when in the last 20 years, there was no further decline neither in the incidence rate nor in the mortality rate of cervical cancer in Germany, despite this high effort of performing every year a cervical smear from women starting at the age of 20, as I said, with no upper limit. The reasons could be either the low sensitivity of cytology for the detection of pre-cancer, which is about 50%. And the other reason could be also that we have already a low attendance rate, not exceeding 65% in the population, which is actually dropping, then has a sharp decline starting at the age of 50. And that is really a problem because the mean age for cervical cancer is actually in very young women with the age of 52. And so this combination of lacking sensitivity of cytology and low attendance at the age where it becomes really important could be a reason for the lack of success in the last 20 years. However, as it has been shown in numerous studies, that a persistent infection with high-risk types, of which 13 types of human papillomaviruses have been declared as carcinogenic for human beings by the WHO, it became clear that we could not only perform cytology, but we could also perform testing for these 13 high-risk types where a persistent infection is a necessary risk factor for cancer. And this slide shows you actually a combined analysis of 4 randomized controlled trials from Europe, from Sweden, Netherlands, Italy, and UK, with 176,000 women with the endpoint of cervical cancer. And those women received either cytology or an HPV test at the baseline, and then were followed up for about 6.5 years. And you can clearly see that the risk for the development of cervical cancer is much higher in those women that were at baseline normal in cytology as in those women that were at baseline negative by a test for a high-risk HPV type. This was actually confirmed in a much larger population that was from the Kaiser Permanente Northern California trial, where in the hospitals of this group, they started already 2003 performing co-testing, meaning they performed an HPV test plus cytology on each woman. And then there was a follow-up of about 5.4 years. And the endpoint here was now pre-cancer or cancer. And again, you can see that women that had at baseline a normal cytology had a higher risk for developing CIN3 plus than those women that were negative for a high-risk HPV group type test. But then they also analyzed what is the outcome in those women that were either cytology positive or HPV positive or both. And they could, because of they investigated a large number of women, they could actually show a significant but small increase in the sensitivity of co-testing in comparison to primary HPV screening only. And that was the reason for the US to go for co-testing, and also in Germany. However, one should not perform HPV testing in women that are younger than 30 years, because the prevalence of those high-risk types in women at the age of 22 or 25 is really high. And you would actually send a lot of women unnecessary to follow-up investigations because most of them have only transient infections. So in Germany, what we do now, from the age 20 to 25, 20 to 35, those women have an annual cytology, and those women that are below the age of 30, in case they have an abnormal cytology like an ascus or a high-grade ascus, they have a repeat cytology within 6 to 12 months. When they are above 30, they don't get a repeat cytology. They get an HPV test because in those women the prevalence is already lower, and if this test is positive, they will be recalled in about 6 to 12 months and have another test again. And clearly, those women that already have a high-grade cytology like CIN3 or higher either go immediately or within 3 months to colposcopy. In women that are above the age of 35, they have a real co-testing. That means every 3 years now, they have a cervical cancer test. And those 3 years are important because if you make the interval minor, so 2 years or 1 year, you would also pick up those women with a transient infection because the transient infections actually can stay up to 1.5 or even year or even 18 months. So 3 years is very important. When you test for HPV, you have to increase the screening intervals. And now if women are positive in either HPV or in cytology, they have, and if this is a low-grade cytology or only HPV positivity, they have a repeat test after 1 year. And now again, if they have a higher grade cytology and are HPV positive or even CIN3 or more, they go immediately again after 3 months to colposcopy. Now, so it says an HPV test has to be performed, but which kind of test? And this is important because there are different ways of actually to detect human papillomaviruses. Either you can look for the virus by itself, but this has been done by electron microscopy and it's not suitable for cervical cancer screening. You can look for the viral nucleic acid, which is in the case of papillomaviruses DNA. So you would use a DNA-based HPV test, or you can look for the messenger RNA that is transcribed from the viral DNA. And this is done by a messenger RNA-based test. And here you pick up actually only the active infection because these messenger RNA is only in cells that have an active infection where the DNA, as I said, already is transcribed. You can also look for the viral oncoproteins, but these tests are not sufficiently investigated so far. So when you look now, we have in the last review, we found that there are only 254 commercially available tests on the market. They are different by design because they are tests that look only for the presence of one or several of these high-risk HPV types, but do not differentiate which types are there. Some tests have also partial genotyping. For example, they look for the most important types like HPV 16 or 18, which are responsible by itself for 70% of cervical cancer. They do full genotyping also for other types, but there are only few tests that look for the viral messenger RNA. And those tests are not only different by design, they are also different by the genomic region that they pick up. So you can see here the genome of human papillomaviruses that is usually a plasmid, so a closed structure, but now you see it in a linear form presented here. And when we go from the bottom to the top of the slide, you can see the different tests look for different genomic regions. For example, this test here, which is a genotyping test, looks only for the presence of the viral DNA that encodes the regulatory protein E1. The hybrid capture 2 test, which was the first test approved by the FDA for cervical cancer screening, actually uses full-length genomic RNA probes to detect the viral genomes of the high-risk types. The COPAS test by Roche or the real-time high-risk HPV test by Abbott looks only for the presence of the viral DNA encoding the late capsid protein, which is actually the protein that builds up the vaccine that is used nowadays. The Savista test is only positive when 3 genomic regions are present, and especially when the genomic regions for the viral oncoproteins that encode the viral oncoproteins are there. And there is one RNA-based test, the Aptima test, that looks only for the transcripts of the viral oncogenes. So you see there are either differences in test design or in the genomic regions that are detected. So it's important to know which test can be used and which test has been used actually. And as papillomaviruses do not infect single cells, but they infect actually cells that are within an epithelium, like the ectocervix of where we have a differentiated epithelium, stratified epithelium, which we can see here. So we have different scenarios. Either you have a latent infection where you have only a few cells that are infected. This is clinically not important to detect, and only very highly sensitive tests will pick up this test, this latent infection, and you should not use those highly sensitive tests. Then when we go from CIN1 to CIN3, we can see that we have those purple cells. That means that are cells usually in this epithelium, only the basal layer contains cells that are able to divide. Within the epithelium, when we go from the bottom to the top, we have an ongoing differentiation of the cells, and they undergo a terminal differentiation program. This is still there in the CIN1 lesion, and this allows actually the papillomaviruses that are in this epithelium still to replicate and to produce new viral particles. That means in some of these cells at the top, we have up to 1,000 genome copies per cell. And so you have, when you look at the complete epithelium, you have a lot of DNA in this epithelium. And in these purple cells, you have the expression of viral transcripts, and also in some of those cells up here. But here you have much more DNA than RNA. When we go now to CIN2, then the epithelium does not undergo a fully differentiation anymore and does not allow the virus to propagate. But we have up to 2/3 of the epithelium that are built up by these abnormal cells that are still able to divide. So we have many more cells expressing RNA, and because we have no viral propagation anymore, we have lost this high DNA load. So with ongoing progression, we have actually more RNA and less DNA, and this is even more supported by the fact that with a higher grade progression, CIN2 or CIN3, we have also integration of the viral DNA into the host genome, leading to a loss of the viral repressor E2, and this again causes an upregulation of the viral oncogenes E6 and E7. So it means with ongoing progression, we have a decrease in the DNA and viral load, integration of the viral genome, and increase of E6 and E7 messenger RNA. I will quickly show you the results of a German screening trial we performed, where we did a co-testing with HPV and cytology. We used a liquid-based cytology, and out of this single smear, we did the RNA aptamer test, we did a DNA hybrid capture test, we performed cytology, and when HPV was there, we also did genotyping and looked for the type present. Quickly to show you the results with regard to the sensitivity and specificity of the DNA-based test hybrid capture, or the aptamer test, the RNA-based test aptamer. You can see on this graph here, sensitivity from 0 to 100%, and specificity as 1 minus specificity. So the ideal test would actually be here, and you can see there is no significant difference in the sensitivity of the aptamer test versus the hybrid capture test. However, there is a clear significant increase in the specificity of the RNA, meaning you have less false positive women, so you have less referrals to colposcopy using an RNA test than if you would use a hybrid capture test. What now? And here you see the raw numbers. We picked up 90 CIN2 and CIN3 in these 10,040 women at 3 clinical centers in Germany in this cross-sectional study. And what would be the effect of co-testing now? Cytology actually would have missed 26 of CIN2 and 20 of the CIN3. However, cytology brings actually one more lesion that has been missed by the RNA-based test. So there is again a slight increase in sensitivity when you do co-testing than if you would do only HPV testing. We performed also a follow-up study on these 10,000 women, where we invited those women that were negative in all tests after 5 to 6 years again, and performed the same set of testing as I showed you before. And on those women that were positive either by cytology or by HPV, or in both cases, those women were regularly invited every year for up to 5 to 6 years. And when they were positive in any one of those tests, they had to undergo colposcopy within 8 weeks. And when they found a lesion, this lesion was removed. And when there was no therapy, they attended 1 year again later. And this shows you now the result of this follow-up analysis. So in total, we had 9,451 women that were negative in all 3 tests. From those, we recruited 4,000 women after 5 years, and 3,295 were eligible. And in this group, we had a very low incidence, 0.3% of CIN3 and CIN2 cases. In the other women, where we had 699 that would be eligible for follow-up. However, we had to deduct those that were treated. So in the end, we had 606. 195 did not attend, and we had again these 3 groups that were either cytology or HPV positive at baseline, 60 women, and in this group we had the highest incidence clearly of CIN3 and CIN2, 13%. Interestingly, in those women that were at baseline cytology positive but HPV negative, we had not a single case of CIN2 or higher. And in those women that were cytology negative but HPV positive at baseline, we had about 8% positive, 8% detection of CIN3 and CIN2. So this is again shown here as a cumulative risk of CIN3 after a negative baseline test per 1,000 women. You can see women that had only a cytology negative, that were cytology normal at baseline, had a much higher risk than those women that had either RNA-based HPV test or a DNA-based HPV test. And this difference here shown, and shown again here, is not significant. Now, the problem is now when you do only, in cervical cancer screening, you do only 1 test at the beginning. And if this test is negative, then you can send women back to routine screening. However, if it's positive, you have to perform a triage test. And if this triage test is positive, you have to send them to colposcopy. So you can actually overcome this this complicated scheme when you do co-testing. And this was again in a retrospective analysis, again at the Kaiser Permanente Northern California trial, analyzed, where in total 1.2 million women with an age of more than 30 years, where co-testing was started in 2003, analyzed. And you can see they look here at pre-cancer and cancer. Now let's only look at cancer for time reasons. You can look at the other numbers by yourself. The detection rate, if you perform co-testing, and if either cytology or HPV or both are positive, for all cancers, it's actually interestingly low, only 83%. For squamous cell carcinoma again, and for adenosquamous carcinoma even a little bit lower. And when you would look, however, co-testing is much better than if you perform only HPV or only cytology. Again, cytology brings you a slight but a significant increase in the detection rate of about 5.9% for all cancers. Now, this number here is really surprisingly low, I have to say, and this could be because this is a real time and real life data. This is not a study trial, so there might be no follow-up on those women, or the women did not attend, or they were not asked to go to a follow-up, or there must be, or there could be also misinterpretation in terms of histopathology. And this is one reason where we actually investigated in a study, which I cannot show you because of time reasons, with 370 cancers, that most of these HPV negative cancers actually are not really cervical carcinomas. This is again graphically shown here. Here you can see, you look at all cervical cancers here. Here you can see women that are positive by cytology and HPV in the years prior to diagnosis. And you can see HPV adds a lot of detection and cytology adds a little bit more, but at the end you gain about here almost above 90%. Now, when you repeat your screening rounds, you can see that the risk in co-testing or in primary screening, that the risk of CIN3 actually decreases with each screening round. This is the first screening round, it's the second round, and the third round. So you have every time you have a decrease. However, even after a negative single co-test after the first screening round, you could not see any interval cancers coming up between the screening intervals when you do co-testing, but also when you do HPV testing. Now, coming to the tests that could be applied to cervical cancer screening, it is important to keep in mind now that we have to have long-term data, because I told you screening rounds have to be at least 3 years in some countries. The screening intervals are actually 5 years. So a test has to be a proven evidence that the negative predictive value of this test keeps up to stay high after 3 or 5 years. And so when you look on the published data, and when you look what tests are actually approved by the FDA or have a CE certification, which is not really telling you anything at the moment. So better look for the FDA approval. You can see there are only 5 tests that have an FDA approval so far. All of them fulfill the so-called Meyer criteria, which have been published criteria that a test should perform. However, when you look for the peer-reviewed evidence level in the publications, you see only for a few tests you have sufficient evidence. And when you look now for the negative predictive value over 3 or 5 years, you can see only 3 tests actually fulfill those criteria. So at the moment, one could only recommend the hypercapture, the Aptima, the Cobas Roche, the real-time Abbott, which has, however, no FDA approval, and probably there will be soon data coming out for the Clarity test from Beckman Dickinson, covering at least 3-year period. The other tests are either not suitable for mass screening or are no longer on the market. So to sum up, regardless of study design, we found similar sensitivities of the DNA and the RNA test, Aptima and hypercapture, for the detection of CIN3, and always had a higher specificity of the RNA test. One has to keep in mind, as the screening intervals lengthen to 3 to 5 years, we need new criteria for longitudinal data, and there are only published data for 10-year follow-up for hypercapture, Cobas and Aptima, and 3-year follow-up for the Abbott HPV real-time assays. These longitudinal studies show same longitudinal sensitivity and NPV for the RNA test. However, the referral rate is much lower for the RNA tests than for the DNA tests. We can observe when we do co-testing a decreased risk of invasive cervical cancer and CIN3 plus risk within each co-testing round, and a single negative co-test actually rules out CIN3 and cancer effectively, so that after the second co-testing, no interval cancers were found. The increase by cytology for the detection rate in co-testing was small but significant, 5.9%. in this study with 623 women. A positive co-test was slightly more likely again for pre-cancer and cancer than doing HPV testing alone. And the main explanation for HPV negative cervical cancers, however, is false histopathologic diagnosis. And the other reason is that these are cancers that are not associated with the high-risk HPV types defined by the WHO. And with that, I would like to thank my co-workers, especially the group from Peter Sassini from the University College London, and all the gynecologists and all the women that participated in our study. And also I would like to thank you for your attention to listening to this talk. Спасибо. Thank you.